with the frontline treatments and therapies, do you have any, sort of knowledge to impart on what the most common side effects typically are? I know they vary widely depending on the person as well, but
Sure.
people question, how do I manage this, the side effects? And this will be a common theme in the conversation as we talk about these different areas of therapy.
So that's a great question. Before I start, I always say I use my two hands and I point to my chair and I say, everything I say, it's easier said from this chair, right? Meaning from a doctor perspective, I realize I'm not the one who's going to be going through the treatment, but I can explain, I think, quite well, just because of having seen hundreds or thousands of patients being treated, that you understand what to expect. So I would put it in the following general terms. The antibodies in general are incredibly well tolerated. And there's some issues that we talk about with infusion reactions or injection reactions, but they're really almost not a problem from a medical side. Everyone gets through them. And I don't have a single patient where we have not been able to get through with the antibody administration. So that's pretty straightforward. It sounds more scary than it ends up being in general practice. When we talk about the drugs that are called the immunomodulatories, and the most common one is lenalidomide, that comes in a pill form, and that has a few side effects we need to look out for. It's pretty common to have some fatigue. So that's almost expected. In some circumstances, patients will have a rash. It's not really an allergic rash. It's a bit of a rash, and sometimes it gets better. So we try to kind of just push through that with some symptomatic treatment, although it can be severe, and the medicine has to be stopped. And the most important part with those medicines is that they increase the risk of someone forming a blood clot. So we ask patients to keep moving around, stay well hydrated, but we have to put a preventive, blood thinner. So either an oral blood thinner, which is the most common one, or others. But in some circumstances, we have used aspirin. I'm kind of moving a little bit more towards the anticoagulants just because of the seriousness of the clots, but that's what we do. The class of drugs that are called the proteasome inhibitors, one of them, the bortezomib, is the one that goes under the skin. That one we have to monitor very closely because there's a toxicity called peripheral neuropathy where people get inflammation of the nerves. The consequence of that is decreased sensation and in extreme cases, pain or dysfunction. So we don't want to get there, and we can interfere, but we need to hear from patients. The other drug in that category is called carfilzomib. Now, carfilzomib has other toxicities. It's been called cardiorenal, so we have to look at blood pressure, and there could be some issues with heart function or kidney function. We monitor for that. In most cases, that is reversible. So from what we've seen, if you have to stop the medicine, things come back. So that's something we know. So that's for the three main drugs. That's kind of my standard. The hardest part oftentimes is the fourth drug, and that is the dexamethasone. Dexamethasone belongs to the steroid class, as you know. It's a corticosteroid, and it is a tough drug. I think patients and families tell us that this is one of the hardest parts of the treatment. I usually tell patients, imagine if you take your medicine, you take your dexamethasone on Monday. It's like Monday tells the rest of the week, all those days, hey, send me all your energy. I need it for Monday. So, Monday, Tuesday, and Wednesday, there might be a peak where someone has a lot of energy, and then starting at some point in Wednesday, you're out of energy. You've used it all, so that then you start going into this lull. So there's a little bit of a cycle like this when you use dexamethasone. Dexamethasone, it's the other way of describing it. I tell patients, it's like you drank 3, jars of just hard coffee. So you're going to be talking a lot. You're going to be awake. You may have difficulty with insomnia. And also the human brain reacts in a little bit of a funny way with dexamethasone. It makes us impatient and it makes us edgy. So I warn patients and families, this is temporary. Don't, hold it against them. It's going to get better. And the best explanation I have for that is, imagine you're in the highway and you're stuck in traffic. I don't care how patient you are. We all start becoming impatient and, start losing our temper, right? So Mother Teresa on dexamethasone would have been probably a mean person. So it's really important that we advise patients about this, and that, it will get better. But sometimes we have to even either stop or decrease. And then there's some other issues. Patients can have problems with management of their blood sugars. So someone who's diabetic may have a harder time with dexamethasone. So that's kind of in a nutshell how I would think about all those treatments.
Thank you so much. I know it's a lot to get through, but I'm so glad you even painted such a vivid sort of picture of the experience on dexamethasone. I've been on steroids for my cancer treatment before. I can attest to a lot of what you're talking about. But it is about just having the expectations and managing, right? So that's why you describe this to your patients. Dr. Fonseca, you also mentioned sometimes, patients may experience more severe side effects, and they'll either have to have the dose decreased or they have to be taken off of the drug altogether. In those situations, do you just switch to another drug in the same class, or how do you think about moving forward from there?
It all depends. And sometimes we decrease dose, sometimes we change the schedule. People would like to think sometimes that medicine is also kind of very, very regimented, but there's quite a bit of an artisanal aspect, if you may, of how we go about this. People say, I need a week break. We have to give them a week break. We have to change the dose of a particular medicine. If there's a serious toxicity, sometimes we can't proceed. So we have to stop and we have to change to a different class of drug. But I think for patients, as they hear about this, it's important that they know that there are options. So the important thing is you report, your symptoms and how you feel to the healthcare teams, and be transparent about that. And the fortunate situation is we have many treatment options. So I have patients, as an example, patients that are going to go through stem cell transplant who maybe don't respond to the first combination, then respond okay to a second one, but have a side effect. Then we try a third one. And I'm talking about a real case, and the person had come in with renal failure, really tough situation, but the patient could get through a transplant, and now we're many years out from that, and he's doing very well.